Okay, our next presenter is Dr. Mohamed Maher. Dr. Mohamed Maher is a PGY3 anatomic clinical pathology resident at the Department of Pathology and Lab Medicine in East Carolina University. And Dr. Mohamed was a former colleague here at Sheffield Oman Oncology Hospital. Dr. Mohamed, can you hear me?
Perfect. Thank you so much. Good morning, everyone. Thank you, Dr. Mohamed Kamal. Thank you, Dr. Amira, for hosting this amazing event. Thank you for letting me be part of it. As Dr. Mohamed said, I was a former resident at Sheffield Oman, and now I'm 30 resident at East Carolina University, Greenville, North Carolina. Today we have a quick talk about a rather unusual renal neoplasm. So our story begins with a 52-year-old male patient presented to an outpatient urology clinic with the main complaint of intermittent repeated gross hematuria and episodic left flank pain. At the time of presentation, he denied any symptoms related to weight loss, bone pain, or night sweats. His urine analysis was positive for blood, however, his PSA and creatinine were within normal limits. This presentation prompted a CT scan, which as we can see here in this coronal view, there is a 2.5 centimeter enhancing mass in the left kidney with a polypoid component near the left renal pelvis, which would explain the renal hematuria. The mass extended to the uretero-pelvic junction with mild hydronephrosis of the left kidney. Given the presentation and the radiologic finding, urothelial carcinoma was on the top of the differential diagnosis for the clinicians at the time. Non-invasive diagnostic attempts were initially considered. Shown here on the left is cytologic evaluation of voided urine, and on the right is renal brush cytology. Both revealed predominantly hemorrhagic samples, however, only few cell clusters, as the ones shown here, were identified. These clusters had these shaggy, interrupted edges, and if we go on high power, they are relatively uniform, bland, the spindle cells with tapering cytoplasm on both ends. At the time, this was categorized as a typical favoring reactive urothelial process. However, there was a strong recommendation for further sampling to completely rule out any malignant process. And of course, because clinicians rarely listen to us, they gave us another biopsy. This time showed this small, very minute fragment of small monomorphic spindle cell proliferation. However, that specimen was very scant and further evaluation was not feasible. So again, this was diagnosed as highly suspicious, however, not yet diagnostic of malignancy. Finally, we reached the laparoscopic management. This was a robotic-assisted laparoscopic left radical nephrectomy, and gross examination of the specimen showed this tan pink, irregularly shaped polypoid mass, primarily located in the upper pool of the kidney, measuring about 3.4 centimeter, present within the calyces of the upper pool. That mass was soft, friable, however, it was grossly confined to the kidney. However, grossly, there was high suspicion of involvement of the renal sinus. Now to the histology, and as we can see from this low power view, this tumor is very hypercellular. However, most of the cells are monomorphic spindle cell proliferation, forming a rather solid mass. If we go on high power, we can compare the size of these cells to the adjacent urothelium. We can see that they're small, monotonous, relatively small, displaying scan cytoplasm, ovoid hyperchromatic nuclei, NC ratio is high. This is another high power view, and we want to show here that distinct pattern that this tumor showed in certain areas. Architecture-wise, these spindle cells were arranged in these dense, short fascicles with a little bit of vague storiform appearance. Extensive lymphovascular invasion was identified, as we can see in the smaller figure. Hemorrhagic foci and tumor necrosis were approximately 10% of the overall tumor cellularity. So at this time, that morphology opened a rather wide door of a long list of differential diagnoses that will include urothelial carcinoma, sarcomatoid renal carcinoma, and other sarcomas. Therefore, extended IHC panel was in order. So we start now with pancytokeratin. As we can see here, pancytokeratin was mostly negative. Next, we have GATA3, and however, GATA3 demonstrated a little bit of focal patchy positivity within tumor cells. These are not background lymphocytes. These are actually tumor cells that has a little bit of focal patchy positivity for GATA3. Similar image we're seeing was, or similar action was seen was with PAX8. We still had these patchy positivity in tumor cells. At this point, despite having this PAX8 and GATA3 positivity, the negative pancytokeratin and the morphology argued very much against the carcinoma diagnosis, so we expanded our IHC panel. And this is some of the IHCs that were performed at the time to try to categorize the tumor. CD45 only highlighted the background lymphocyte, 34 only highlighted the vasculature within the tumor. However, all these markers, CK720, Amacar, Desmin, WT1, S100, and HMB45, all were negative within the tumor cells. And finally, we had this marker that was our breakthrough within the case, that is TILI1. And we can see the diffuse, strong immunoreactivity within tumor nuclei, indicating a positive TILI1 immunoreactivity. So before we jump into any conclusion, I know TILI1 means for most of us that this could be a synovial sarcoma, and that definitely wasn't a differential. We need to remember that TILI1 is rather sensitive for synovial sarcoma. However, it can be expressed in other entities that can share morphologic appearance with synovial sarcoma, such as peripheral nerve sheath tumor, including neurofibroma, schwannomas, MPNSTs, and solitary fibrous tumor. So we'll follow that with FISH analysis. So this is subsequent interphase FISH analysis that was performed using break-apart FISH probe, the detect rearrangement of the SS18, or formerly known as the SYT gene. And as we can see here, we detected the break-apart signal in about 70% of tumor cells. So that gave us the final diagnosis of primary renal synovial sarcoma. An additional finding when it came to further molecular analysis, using the Tempus XT version 4 assay, there was a somatic missense variant of the ATM gene. Now, the significance of that specific variant is still to be studied. However, it was something that we found during molecular analysis for this tumor, and this given us our final diagnosis of primary renal synovial sarcoma. So a little bit about this entity. Sarcomas in the kidney overall are rare malignancies. They account for only less than 3% of all renal neoplasm. Within these rare sarcomas, leiomyosarc is by far the most frequent sarcoma arising from the kidney, about 40 to 60% of the cases, followed by liposarc, about 10 to 15% of the cases. Other histotypes include rhabdomyosarcoma, fibrosarcoma, and angiosarcoma. Clinically, as we can see a little bit from this brief literature review, primary renal synovial sarcoma can present similarly to other renal neoplasm. There is no distinct clinical features or clinical manifestation that specific for synovial sarcoma. Primary renal synovial sarcoma ranges in size between 1 up to 35 centimeter, with a mean of 10.4 centimeter. The reported initial clinical presentation are entirely non-specific, including flank pain, about 30% of the cases, hematuria, about 30% of the cases, less commonly lumbar pain, weight loss, fever, and fatigue. One very interesting case report of primary renal synovial sarcoma was reported as an incidental finding found during post-renal allograft surveillance. So what we just need to remember from this brief literature review is that the clinical picture radiologic finding are entirely non-specific when it comes to primary renal synovial sarcoma. So always keep sarcomas within the differential, especially if the morphology supporting that. Going back to our patient, unfortunately, he presented 3 months later with widespread metastatic disease, and he decided against any form of treatment at the time. This is just a summary of everything we discussed, and I would just like to stop at the GATA3 positivity. GATA3 has been reported before to be associated with a worse prognosis when it comes to certain soft tissue sarcomas. For example, this is a paper that discussed this specific finding. They include a lot of soft tissue tumors at the time. They didn't include any visceral malignancies. They included leiomyosarc, certain subtypes of liposarc, malignant peripheral nerve sheath tumor. There were no synovial sarcomas involved in that study. However, it is definitely something to explore whether or not GATA3 positivity can have a really bad prognostic, or can be used as a bad prognostic marker for these cases. Finally, I would like to thank Dr. Shujun Chen for his supervision and support, and these are some of the references I used for my speech today. And before I conclude, I want to take a moment and think of all of our healthcare worker colleagues who are dealing with devastating circumstances in the Gaza Strip. According to the WHO, last month, more than 220 healthcare workers have been killed in Gaza by Israeli attacks since October 7th. This level of aggression against healthcare workers is unprecedented, and among those is the man in this picture, Dr. Mahmoud Dabbour. He was one of the very few practicing pathologists in Gaza, and unfortunately he was killed in the recent event. We all need to remember that healthcare workers are never a target in any conflict. Thank you so much for your time, and please have a good day.
Thank you so much, Dr. Mohamed, for your presentation. We are glad to have you here again and inshallah always with us. Thank you so much.